First of all, I just want to thank everybody for coming out today. I'll just go ahead and address that we have a lot of information, so we're going to fly through it pretty quickly. So I apologize if we talk rather quickly. So we'll be happy to answer as many questions as we can at the end. But in case didn't hear, our project is examining proximal hamstring tendinopathy in UltraRunners, a multifactorial approach. So go ahead and start. What we wanted to begin with is basically an introduction to our case. This first started last semester while we were in our advanced strength conditioning course. What we had was a semester-long strength and conditioning project in which we were assigned a random client. This project would last 6 weeks, and what we were supposed to do was meet whatever that client's goals that was in at the end of the semester. We were given kind of a special client here. What he is a 49-year-old male who frequently participates in what's called an ultra marathon. He's been running an ultra marathon since 1998, but since, due to injury, he has been on and off since then, so about 12 years now he's been competing. He's also a former Division I track athlete, and he just is one of the most elite athletes I think I've ever met. I mean, what this guy does is pretty crazy. So as for this semester, he, after the project was over and done with, he contacted us again in February and asked to continue some type of research and development with him since we saw some pretty great progress in the fall.
So we wanted to do a little introduction and kind of a history of ultramarathon running because I know a lot of people might not know about it. Coming into this project, I know Chandler and I knew hardly anything about it. So our client became our content expert and it let us do a little research. So an ultramarathon is anything above 26.2 miles, which is your typical standard marathon. And there's a lot of different types. So one example I have is a city block race, and it's called the Self-Transcendence 3100 mile race. And interestingly enough, as long as it is, it takes place in Queens, New York. So they run around an extended block between June to August and complete this. And then the other example I have is the Fat Dog 100. And it is a 120-mile mountain marathon that takes place in British Columbia. And interestingly enough, the elevation changes throughout that race are almost the equivalent to that of Mount Everest. So it is a very grueling race. As far as popularity, it's doubled its participants in the past decade as a sport. We have a little graph you can see down through here that goes from 1980 up to 2013 and shows it. Really gained traction in the 1980s with the formation of the IAU, which is the International Association of UltraRunners. And just to put it into perspective, in 1985 there were 5,800 participants, and in 2013 there were almost 70,000. So it's growing at an exponential rate. So the problem, proximal hamstring tendinopathy. So what exactly does that mean? So before I go into that, I want to explain that with the boom and popularity of ultra running, there's also been a higher incidence of reported cases of this injury. So to break that down, I think most people know the hamstring. You think of the back of the thigh. It's made up of three muscles. So you have your semimembranosus, semitendinosus, and biceps femoris. As far as what we're saying when we say proximal, we're talking about the origin of the muscle, which is right there in our little red bubble. So it originates from what's known as the ischial tuberosity, or what most people call the butt bone. Basically, tendinopathy is sort of a catch-all term for an unspecified injury to the area. I know a lot of the times we hear tendinitis, which is just an acute inflammation of a tendon, and then we hear tendinosis, which is a chronic breakdown of something at a cellular level, such as collagen. So tendinopathy is a little more of a catch-all term. So to go with that, we have an unspecified etiology, and that just means the cause, so not exactly able to pinpoint it. For our specific case, this started around 6 years ago for the client. It's been a continuous issue for around the past 3. So with that, in that time frame, the treatments prior to us, he sought out help from physical therapists and actually seen a specialist in Massachusetts and provided some relief from those, but nothing that was substantial enough to feel like he competed at a high level. So once we met with him, our goal became pain-free running and pain-free running at long distances and speed work, because not only is he trying to accomplish these long distances, he's also wanting to do them in a specified time. So it was a big component to try to get him up to those speeds where he could compete again.
So when we first started to date back a little bit, October when we started with him, the first thing we wanted to do was look at his biomechanics. The picture we have right there I know can be a little confusing. But what it basically means is that little funny triangle looking thing at the top represents the hip. And this little spot here is the patella, which represents the knee. What it shows, and each muscle is labeled there, is basically shows how different muscles cross multiple joints at a time, how they all work together at the same time. So when we first looked at him, first time we met him, we just did simple things to look at his flexibility, his mobility, his stability and balance, which led to us finding an extreme glute and abdominal weakness. For example, when we first met him, we just asked him to stand on one leg just like this. Immediately when we started to do that, we saw the hip drop, which means the glute weakness. And he wasn't able to stand on one leg for more than about 10 seconds. So as we went on to this, our evaluation process, which is the next slide, we have all our data, we started measuring all of his flexibility as well as his mobility. You think about an athlete as elite as this, which, for example, I can think of about a month ago, he was running about a mile in a trail going up around 3,000 feet with running a full 26 miles with about average 8-mile pace. This is somebody that's just an extreme athlete. And to look at that and find that he has these type of deficits, it's still able to move the way he is pretty amazing. So if we go to the next slide, we can see all our data here. I know it can be a little overwhelming and confusing at first, but what we have at the top is where we have measured all of his range of motion. The next part is where we manual muscle tested everything around the hip, and our special tests on the bottom. And you can see the dates up at the top where we have our first meeting, our second meeting, and our third meeting. It was a 6-week program, so we met the first day, the 3 weeks in, and then the 6-week mark. As you can follow across, we can see that he did have some pretty good range of motion increases that's measured with the goniometer to measure the joint angle. So that's in degrees up there. Manual muscle testing also got a little better. He always has just this little bit of pain in the hamstring, so that's still a little unknown area. And then our special tests changed a little bit as it went on, but we did see a little improvement there. So as for what we did in the fall, what our actual procedure was we tried to get a hold of that muscular imbalance, address his posture, really stretch, because a lot of athletes in here, I know there's quite a few here, nobody likes to stretch, nobody likes to warm up. It's a pretty common problem. So what we did here was a different approach, because we knew this hamstring problem that we didn't quite know what it was. It's been lingering for all this time. We weren't aware of too many diagnostic imaging things that have been done for it. So we took this kind of out there approach where we tried to bring all the other muscles up to speed. So when we saw the stability problem, which you couldn't stand on one leg, we saw the extreme glute weakness, the abdomen weakness. When you stand on one foot, you're supposed to make your abs real tight and stand real strong. What we did was we brought all those muscles up and didn't even really address much of the hamstring besides stretching. And that is pretty cool to see the kind of results that we got. As we go to the next slide, these are the simple exercises that we did. We didn't do anything crazy. We just had some glute bridges. We did the stability exercise. We also had some planks and some simple squats. And if you look at our next slide here, where we have our results, it's a little dark. But what we have here is that was the first day. We've got 3 weeks in, and then the last day here. So if you notice right off the bat, the first day we had a resistance band around his knees. That's to activate his external rotators to keep his knees from falling in. It's obvious he's real off balance. His feet are in the right position, but that's kind of because we told him to. And as we look to the next picture, we have 3 weeks in where his flexibility has increased exponentially. He's well below 90. His back's in an all right position, feet shoulder width apart, knees over his toes. And we look here, he's not quite as deep due to some problems we had with getting to the gym towards the end of the semester with the whole beaking problem they had. So we didn't get the same equipment that we had prior to that, but his back. So we still managed that flexibility part. His back's in much better shape than he had.
And just to add to that, the reason that we kind of took this approach is if you try to find research on this topic, like I said, it was a fairly new injury that started popping up more. Most of the research that you'll find is from 2013 to now. There isn't a whole lot out there, and with a lot of injuries, say like an ACL, a rotator cuff repair, a total knee, there's a lot of accepted treatment plans that are kind of the basis that people go off of. With this, there are a lot of different ones out there, but there's no one thing that says this is the best way to go about it. So in this whole process, we were trying to find our way to do it and potentially make something that we could use in the future. So as we started examining all these things, we started to learn more about something called lower cross syndrome. So this might get a little complicated with anatomy. I'm going to try to explain it as I go. Basically, if you look at these lines, so you have weak abdominals crossing to weak glutes and tight hip flexors crossing to tight thoracolumbar extensors. What this means, basically the muscles that are involved. The weak abdominals, we're not talking about the six-pack that everybody thinks about, rectus abdominis. We're talking about something deeper, which is your transverse abdominis. Huge stabilization muscle. Think of it as a natural back brace that engulfs the core of your body. With the tight hip flexors, we're focusing on what's known as the iliopsoas and the rectus femoris. It's not really important you know what those are, just know they cross the hip. Tight thoracolumbar extensors, we're talking about quadratus lumborum, multifidus, and your erector spinae, so those types of muscles that are responsible for spinal extension. And then a weak glute max, everybody knows what the glute is, so your primary hip extensor is your glute maximus. So what you get, basically, and I like to use the term a happy pelvis. I know that's kind of weird, but when you have a happy pelvis, you have strong abs, strong glutes, and everything's loose that needs to be. So you think of your pelvis being in neutral. And when you start to get weak abs and weak glutes, and then the corresponding muscles on the opposite side of the tight, you get anterior pelvic rotation. And I guess I'm going to do the model. So you think of a neutral pelvis, this is your anteriorly rotated pelvis. And then if you think of posteriorly rotated, I can't really do it, but you think of the whole pelvis shifting backwards. So what this leads to when you have this glute weakness is we have glute inhibition up here. So at that point, the glute is not firing optimally. So the implications for the hamstring with lower cross syndrome is, if you think of that picture earlier when we showed the ischial tuberosity, which is the bone where the hamstring connects, it is the inferior part of the pelvis. So if you think of this anteriorly rotating where your hamstring is, it's putting an exponential amount of tension on the hamstring compared to what you would normally have. So